what you heard before, and also gives you an excuse to forget whatever you heard, including this talk. So, I can talk for if that's all right. Yeah.
Yes.
So basically, I'm going to talk about the brain metabolism and perfusion imaging, and I've taken out the perfusion because perfusion and the metabolism match, and show you some interesting imaging. What is dementia? It is deterioration or loss of individual capabilities of sufficient severity to interfere with social and occupational performance or both, and it is the result of the total quantity of neuronal loss combined with the specific location of such loss, and we're going to comment on it soon. So dementia is a major clinical problem, not only for the developed countries, and this is a misconception, or more importantly so for the developing countries, and the World Alzheimer's Report reveals the global cost of dementia at $1 trillion in this year, 2008, with 50 million people living with dementia worldwide, and 10 million new cases are being diagnosed worldwide with dementia. So the incidence of dementia increases with age and doubles every 5 years after the age of 60, so we are all vulnerable to that. And 5% over 65 years of age, and that is the crucial point, and 20% of, or 1/5 of us may have people may have dementia over 80 years of age. And when you look at the incidence, the projected number of people with dementia in different age groups, as you go from one age group to the other age group, your incidence of dementia increases. And when you look at the prevalence of dementia amongst men and women, women being the one in the red, the prevalence, women are at a greater risk of dementia compared to men in all age groups. However, men should not be so smug. Women are at, although women are at greater risk of Alzheimer's disease or dementia, men are at a greater risk of vascular disease, and they will of course die earlier in general, and not have to cope with senile one. So, when, as I said, the growth of dementia, when you look at the growth of dementia in the high-income countries compared to the low and the middle-income countries, it is the low and the middle-income countries where the dementia is rising more. And this is very nice. Number of people with dementia in the world region. So you got the Asia, the Europe, the Africa, and you look at the bars, and this is the entire world region. And when you look at that, as you project the thing, so the incidence is rising, and the world incidence is rising where? Pakistan, Asia, not the Far East, because they are more economically secure. So this is our concern. Our region of the world is the concern for the overall incidence of dementia in the world. In order of prevalence, the common types of dementia include Alzheimer's disease, vascular disease, Lewy body dementia, and frontotemporal dementia. I'm going to show images for this, with the vascular dementia being about 15 to 20%, Lewy body dementia 30%, and then followed by frontotemporal dementia in 5% of the cases. The major causes of dementia are degenerative, vascular, mixed vascular and degenerative in many cases. The diagnosis of dementia basically depends on the clinical history, not from the patient, but from the patient and from the relative, because the patient may not remember, and he doesn't remember, that's why he's there. Or, very importantly, neurological examination like the MMSE score, etc., which is very robust way of doing it, and of course the final way is to do neuroimaging. And because I'm neuroimaging person, and imaging person is imaging oriented, so in imaging you got MRI, functional MRI, and MR angiography. With CT you got CT with angiography with contrast, and fluorodeoxy glucose PET scanning, and HMPO SPECT scanning for looking at the brain perfusion. The one for metabolism and perfusion imaging, you can do amyloid PET and ioflupine or DAT scan, dopamine transporter scan. Nuclear medicine molecular imaging with the brain started in 1990s with the advent of HMPO SPECT, followed by FDG PET in 2000, followed by the DAT scan, dopamine transporter scanning in 2001 to 6 with PET, CT, and MR in 2013, followed by amyloid plaque imaging. Now, so what is the rationale for it? In the neurodegenerative brain diseases, there is a decrease in the brain synaptic activity, which causes a decrease in the capillary perfusion and local glucose metabolism. As a result, specific brain region degenerate and specific patterns of metabolic brain activity develop long before there are structure changes detected by structure imaging modalities. And this is the rationale for doing perfusion and metabolism imaging. And documenting the brain perfusion and metabolism allows identification of disease-specific cerebral metabolic functional brain patterns in neurodegenerative brain disease for the early diagnosis of the disease at a very early stage. So why do we need to diagnose dementia? You can do a neurological testing and your family can tell you you're not there. But the reason is the treatment, because the dementia subtype diagnosis affects the patient management. And this is the reason for it. We have something called statistical parameters. So we do a brain perfusion scan or a brain metabolism scan, and then we have normal age and sex-based controls, and we compare each and every pixel in the brain to that of a normal male or a female of that age group, and we find how many pixels are statistically different, and we then map them. This is called statistical parametric mapping. For example, in Alzheimer's disease, there is decreased metabolic activity in the parieto-temporal cortex and in the precuneus, extending as the disease progresses to the other parts of the cortex. Okay, in the Lewy body dementia, there is decreased metabolic activity in the occipital and the parieto-temporal regions, whereas in the frontotemporal dementia, there is decreased metabolic activity in the frontal and the temporal cortex. So that is why the areas of brain affected with different types of dementia are different. And it is important to map which areas are affected and how severe it is and how much is the spread. So now it is an example of a normal brain PET scan, and you can see intense FDG uptake of fluorodeoxyglucose or glucose, basically looking at the glucose metabolism of the brain. And intense FDG uptake in the putamen caudate nucleus and the thalamus, and high uptake in the cortex of the white matter is down. That's just for comparison. Perfusion scan, the resolution, of course, in the PET scan is much, much better. And these are the various areas there. What is Alzheimer's disease? Of course, is the most common cause of dementia, caused by a reduced synthesis of acetylcholine and characterized by progressive decline in the memory impairment, mostly affects middle-aged and elderly patients. The spread of Alzheimer's disease, when you look at it, it starts in the classic pattern is the impaired perfusion and metabolism in the temporal cortex, and then extending to the parietal lobe in the precuneus, involving the posterior cingulate gyrus. In the advanced Alzheimer's disease, the hypometabolism extends to involve the prefrontal association cortex, and there may be frontal lobe involvement, but sparing of the anterior cingulate gyrus. Now I just show you a case of a early Alzheimer's disease, a case of a moderate Alzheimer's disease, and a case of the advanced Alzheimer's disease, and just showing. This is a 65-year-old male with a history of mild forgetfulness for 4 months, query Alzheimer's or cerebrovascular disease, and as you can see, there is mild symmetrical reduction of uptake, as the arrow shows, in the medial temporal cortex bilaterally, and this is a case of early Alzheimer's disease with no evidence of cerebrovascular pathology seen. And these are the images. Statistically significant areas are lighted up, the rest are dark. So this is mild Alzheimer's disease, and you can see the distribution here. Okay? So in a mild Alzheimer's disease, the primary symptom is forgetfulness. The patient may forget name, addresses, shopping items, etc. The main deficit is in the recent memory, with the intellectual deficits are confirmed by neurological testing, and patient might have some awareness of the symptoms and maybe some denial there too. But there are no distinguishing features on physical examination. Another scan of an 80-year-old female with a history of progressive short-term memory loss, and the patient is an insulin-dependent diabetic, hypertensive, with ischemic heart disease, query Alzheimer's or cerebrovascular disease. And when you look at this, there is bilateral reduction of uptake in the temporal lobes, more in the medial temporal cortex compared to the lateral temporal cortex, and you can see it in the precuneus, and with mild reduction of uptake in the parietal association cortex and minimal reduction of uptake in the frontal association cortex. And this is a case of moderate or stage 2 or moderately advanced Alzheimer's disease. In moderate Alzheimer's disease, the memory loss is significant, and a patient may not recognize close family members, forget about the well-known routes and places, etc. There are personality and behavioral changes. There could be self-neglect. The patient may be disoriented in space and time and unable to undertake simple tasks like dressing himself or herself, reduced range of thinking, which means there is intellectual deficit, language problems, etc. And he may be shameless like me. All right, so we go on to another case here, 61-year-old male with a history of hallucination and memory loss for 2 years, Alzheimer's or cerebrovascular disease, and here you see symmetrical bilateral reduction of uptake in the precuneus. This is the reduction of uptake, and this is the statistical significance, and the posterior cingulate cortex, and moderate reduction of uptake in the parieto-temporal cortex. And I'll show you a few images. This is a case of advanced Alzheimer's disease, very highly statistically significant. So in severe Alzheimer's, stage 3 of Alzheimer's disease, there may be dysphasia with disordered and fragmented speech, aggression, restlessness, hallucination, delusion, incontinence, etc., etc. So I'm going to speed it up now. Lewy body dementia, the second most, I may have to do one more extra minute, is the second most common degenerative disorder, and it is microscopically the intraneuronal cytoplasmic bodies called Lewy bodies, and these are these. And there is nigrostriatal dopaminergic dysfunction with the loss of dopamine active transport, whereas it is preserved in Alzheimer's disease. So this is how you distinguish by doing a ioflupine or a DAT scan in Alzheimer's disease, a good uptake in the cortex and the putamen, whereas it is lost in the Lewy body dementia. In the scan, there is some reduction of uptake in the posterior cortex, but when you do the DAT scan, you can see it is not normal. The other type of dementia is frontotemporal. There is a frontal dominant, there is a frontal and temporal one balanced, and there is a temporal dominant. So these are the three types. We have the frontotemporal one, and then the frontal and the temporal dominant variations. And I'll just show you a scan in the 87-year diabetic with paranoid delusions, etc., short-term memory loss, etc. And you can see severe reduction of uptake in the frontal and the temporal cortex. This is a case of frontotemporal dementia, and this is statistically significant in the images, and I'm sure I'll close it in time. So this is a case of PET-CT shows Pick's disease of frontotemporal dementia, and then we have the other major is a multi-infarct dementia, which results from multiple discrete cerebral episodes characterized by behavioral and cognitive disabilities with history of sudden stroke episode with stepwise deterioration, and the brain spec shows multiple areas of or PET shows multiple areas of hypoperfusion which are randomly distributed, as you can see in this patient here. And the arrows will come and point them to you, and you can see on the CT component these dark areas which are the vascular dementia. Okay, so I've shown you various types of them. The same thing. In conclusion, brain perfusion and metabolic imaging, whether you do it with SPECT or with PET, provides a unique ability to detect early stage disease-related changes in the human brain, monitor their progression in vivo, and help in differentiating between different forms of dementia, and help monitor the treatment response. Thank
you. The important question that comes to my mind is that we treat people with Namenda and with Aricept. Have you seen that intervention with these memory enhancing drugs? Does that make a difference to scanning?
It does not make Yeah, it does make it, but not to the deep, because we're looking for not high areas. And if you do these things, some areas will light up, but that doesn't mean that the areas which are reduced will light up either. So the important thing, and I've deleted a few slides for the sake of time, is that what you give for one may not be good for the other type of dementia. So that is why Aricept, etc. is okay for this, and it doesn't affect actually the scanning. That's your question.
No, it does affect, let me tell you about that. Yes. I mean, you see, I still figure that for the last 30 years of practicing neurology, I see plenty of tons of patients with the dementia, mild, moderate, and severe. The thing is, you know, statistically, these donazepam, the Aricept, and the Lemzaric, the combination of acetylcholine and the Namenda, I mean, it does make a difference. I have patients, you know, if you drop the patient suddenly, you will see the mini-mental status score from 30 always to 25 or 15 or 10. The moment you drop that, it suddenly drops. It does make a difference. I know it's not.
No, but
it does not affect the brain metabolism. It does not affect the fluorodeoxyglucose utilization. It does not affect the perfusion. It is clinically good. It is clinically you're doing it, but you are not changing the brain by itself. You're not changing the degeneration. The cells have degenerated, and they are not going to come back. They are dead, and they will show as dead here.
I think it's stop progression. That's the main
It
thing.
will not stop progression. Slow the progression.
And then you don't forget one more thing. It's called a reversible form of dementia. Not only dementia, Alzheimer's. Check the blood count. Thyroid function test. I'm telling 50% of my patients, they brought the family.
Absolutely.
Disoriented, nothing. I do the thyroid function test. TSH is sky high. You give the thyroid and they get better.
Yeah, but that's not the true dementia. That's not the true
reversible
dementia.
form of dementia and chronic subdural hematoma. They have a old patient, small subdural, more children trauma. They get a small subdural hematoma.
We are talking about neurodegenerative brain disorder. We are talking here in this talk about neurodegenerative.
You know, you should have the prevalence of mobility throughout the world. In Asia, high prevalence. Which type of dementia? Alzheimer's or everything?
I think Alzheimer's is the biggest one.